He had a inferior myocardial infarction, primary angioplasty to RC.
Sorry, injection.
Now he's got a calcific
Sorry,
LED lesion. Can you switch over to the next image? So this is the first caudal image where we are seeing some calcification in the left anterior artery, and the left main looks reasonably okay. The circumflex also looks reasonably okay. Adi, next image. Now in the cranial image, there was some. They have actually done this is done elsewhere. They've done the angio with the EBU catheter because they found it difficult to hook with the Tiger catheter. So now again in this particular image, you can see that there is a critical calcific disease in the proximal left hand descending artery, and you're also seeing that the left main ostium is not a wide left main. In the caudal view, the left main ostium was looking okay. Here in this particular view, next one, cranial view. Adi, next view. In the cranial view, you could see that the left main ostium is not all that normal. There appears to be some 40-50% stenosis over there in the left main ostium. So this is the first case that we are planning to do. So what do you want to discuss regarding your strategy? Vishnu, we'll take a couple of images, caudal and cranial. Pressures are okay, which means that there is no significant left main lesion. Okay, come caudal, AP caudal. Yeah, this is good enough. Okay. Yes. Yeah, it's calcified LED. Yeah. Now come cranial, AP cranial. In this view, there is no significant disease of the left main ostium. Anyway, now we'll go cross the lesion with a regular wire and then do an OCT imaging. Yeah, this is right from the ostium. Very true. Okay, again come caudal, we'll wire it. We prefer either Versaturn, that's Abbott, or run through wires as the workhorse wire. If the lesion is not very difficult, it's always Oxford wires. It being nitinol wire, you can always reshape it and reuse it also. You can always push it in and then orient the wire towards LED, but then there is some amount of disease, always safer that we keep it right at the ostium. In case we are not able to wire it, then probably push it much more deeper in. Now we'll go with the OCT run. Pradeep, show the OCT image on the monitor. That's okay, right? Because there is some distal tortuosity, we'll keep it there. Now we do the OCT pullback. Especially when you have an aorta ostial lesion, you would want to try avoid using a pressure injector, because when you do a hand injection, you see that there is some dissection happening. You can always stop it off. It never happens with the pressure injector. You might have to pull out the guide catheter. So when you have a mildly diseased aorta ostial, when you have an aorta ostial lesion, it's better hand injection. It's always safer, because we've had a couple of nasty dissection, but we're able to tack it. But it can happen. Be ready with the microcatheter also, a New York one. Okay, Vishnu, that's enough. Okay, we'll go with a 20 cc thing. That's a survey mode, 75 ml. Aditya, survey mode. Okay, we have reasonable clearance. I'll adjust the guide little bit in. Okay, we are ready. Here the pressures are good. You ready? Auto calibrate. Yes. Okay. Enable pullback. Okay, now going for cine. Injection. Activate. Okay, that's good. Give microcatheter. The short one, 125. Okay, the image is good. Vishnu, I think we'll go with the mic. We'll take this out, go with the microcatheter and exchange it with the wiper wire. We prefer the fine cross mostly. Stop here. So you can see here in this monitor or on that monitor. So now distally we are beyond the lesion over here. We can rotate. You didn't do the angio registration. It's all right. No issues. Okay, so that's distally beyond the lesion. We can get an idea regarding the blood vessel size by looking over here. It's distally around 3 plus. So probably the distal landing zone, the stent size would be around 3 millimeter in size. Then as we come more proximally, this is all fibrotic disease. From 3 o'clock to 9 o'clock, you are seeing more of fibrotic disease. Here, there is no much of plaque over there in that particular area. And then as we come more proximally, this is more of fibrotic disease. And this is the tightest area wherein the luminal area is around 1.2, 1.3 millimeter square. And there is some calcification. Actually, it's an eccentric calcification. Somewhere at 9 o'clock position, it's protruding into the lumen. And then as we come more proximally, here again, this is 180-degree arc of calcification. It's a calcified nodule. It's more of a calcified nodule and eccentric calcification occupying almost 180 degree, and the other half of the vessel appears to be reasonably okay. And again, you could see that the catheter is actually hugging on to the calcium, which means that you are certainly going to touch that particular area with the orbital atherectomy device. So you would get a reasonable sanding of that particular calcium with the orbital atherectomy device. And then again, this is again 180-degree arc of calcium, eccentric, it's eccentric calcification. And again, this particular case certainly would be the most ideal one for an orbital atherectomy. Here it's almost 270-degree arc of calcification. And then as we come much more proximally, here again, it's almost 270-degree arc of calcification. Here we are reaching almost 360-degree arc. And then more proximally, okay, there we have reached the ostium of the LED. We'll see the ostium of LED. Okay, at the ostium of LED, the luminal area is quite good. It is around 7 millimeters square. Then as we come into the we are seeing the circumflex over here at 12 o'clock position. Then back into the left main, the luminal area are 8, 7. It's reasonable luminal area. And we'll also see the ostium of the left main. Here again, the luminal area is only 5.36, and more of a fibrotic. Probably we'll go ahead and stent till the ostium of the left main, because there is some disease and the luminal area is less than 6 millimeters square. Probably you cannot extrapolate the data with IVS and OCT, but we angiographically also we felt that there is some amount of disease over there, but we are sure that there is no much of calcification in the left main. So the calcium is mainly in the LED. And again, in the proximal areas, we do not see any luminal protrusion of calcification. It is more of superficial plates of calcification. But as we go towards the distal lesion, it is more of eccentric calcium over there. Probably we should be working with the orbital in the more distal half of the lesion rather than in the proximal half of the lesion. Okay. So now we do orbital and then have a repeat OCT done. Vishnu, we changed with the wiper wire. So over the run through wire, we have taken the microcatheter, we have crossed the lesion, we have exchanged with the wiper wire. Now we'll get ready with the orbital atherectomy device. Yes. No, we as soon as we are done with the orbital atherectomy, we switch over to the regular wire. The reason being this is cumbersome, it's a 300 centimeter wire, no? So we immediately switch over to the other one. Okay, are we ready with the device? Okay. So again, that's the crown, 1.25 millimeter. That's the drive shaft and the sleeve over there. So we are connecting it to the saline. Wiper slide. That milky solution, it's a 500 cc saline with 10 ml of wiper slide. So okay, so make sure that there is no air inside the catheter system. Okay, tubes, there is no air inside that. Okay, we are sure about it. Now we'll check this. We'll check the speeds. Normally you would always want to keep it in the lock position when you go inside or when you come outside, and only when you do the burring, when you do the sanding, you need to open the lock and move it forward and backward. So always keep it closed. Now we kept it at 80,000 rpm. You can also make it 120,000 rpm and then switch on and switch off. Make sure that it's okay. Then always make sure that your lock is down, the brake is down. Then only you'll be able to activate it. Okay. So I think we'll go inside. We have kept it at 80,000 rpm. Here the vessel being around 3 millimeter. Once we are done with 80,000 rpm, we'll also do sanding with 120,000 rpm also. Pradeep, we have stopped noradrenaline or shall we keep it? It's around 100, 110, small dose point. Okay, now we keep the brake open and then it's again like the push-pull technique. Like how we do for rota, you can go inside. You can also switch over to the glide assist mode and then push it also. Either are option, but then usually it goes in without any difficulty through the guide catheter, unlike the rota protection. We need to do proper sanding of the second half of the lesion where we see more of calcium in fluoroscopy. Yes. Okay, so we have reached the lesion. Now we'll press the brake and then switch on the toggle the knob and then start off with orbital atherectomy. So BP is 120. Sister, noradrenaline. Okay. So we are ready. We'll go. Always listen to the pitch of the sound also while doing, because you do not have an end point with this device, because with rota you cross the lesion, you have an end point. You're sure that enough of burring has been done, but then here you always need to keep in mind the sound, the pitch of the. We'll go, Vishnu. It goes for 25 seconds. It gives a beep. You stop it. That's. It's like on fluoroscopy, you don't see that it's moving. So that slow should be the movement. No. 25 seconds you're continuously doing, moving. Yes. Yeah. Small. We are not really standing at a particular place. It's a slow movement. Then only you get the maximum sanding. While doing rota, we usually meticulously wait for 1 minute or so. But here with this, 20 seconds is enough. 25 seconds of sanding and 20 seconds of waiting. You can pull it back because it's an eccentrically mounted bar, and if you do not have a very critical stenosis, it just flows. The blood flows. You really do not have, even you can park it beyond the lesion, but then we always try to pull it back in a better place where you have a reasonably or a decent lumen. Yes. Yeah. Okay. In the proximal half, because the lumen is good, probably we'll do with 120,000 RPM. We finish off at low RPMs in the distal half. More of an eccentric thing I see. Again, wait for 20-25 seconds. Pressures are okay. Pradeep, pressures are okay. 130. No much of tachycardia. So we've done 2 runs. Usually a minimum of 5. Again 30 seconds. That is the area where we see maximum calcium and eccentric calcification. We did not hear much of change in pitch. So probably now we'll go at higher RPM. Because when you see a change of pitch, you are sure that it's actually hitting against a calcium. We didn't hear much of, yeah, it was almost same. So we'll go to higher RPM now. The distal half and then the proximal half.
Okay.
We've gone up to 120. Now that's the, yeah. Now we are hearing a pitch difference. So which means that we are touching to the calcified areas. So 25 seconds of sanding and 20 seconds of resting. നിങ്ങളെ ബുദ്ധിമുട്ട് എന്തെങ്കിലും ഉണ്ടേ പറയണം. കാര്യങ്ങൾ ഭംഗിയായിട്ട് പോകുന്നുണ്ട്. ഒരു 15 മിനിറ്റും കൂടെ കേട്ടോ. ബുദ്ധിമുട്ടുണ്ടോ ഇപ്പം? കുഴപ്പമില്ലല്ലോ. Once again we'll go in the distal half and that change of pitch. Now we'll do one more burring of the proximal half at 120,000 RPM and then take it out. Yes. Three balloon. Last one more we'll do. One more and we'll stop. Now we are done with 6 alle. Then following OCT, 3 mm non-compliant balloon, 312, and then we do a repeat OCT and go with stent. Same probably we'll use 2 stents, distally a 3 and a proximal 3.5. Aditya, Sri Lakshmi, 3 and 3.5. Last is. Now we started seeing some ST depression. As you keep doing more and more, invariably you tend to see some slow flow. Okay, we'll take it out. Okay, I've opened the brake, and we'll go to glide assist mode. That's pressing on. You have the blinking light over here. Then we'll go in. Okay, we'll come on. ST segment is better now. Now run through wire. We'll take this out. A shoot, then OCT. Okay, it's come out. Okay. Okay. Once we take out the wiper wire, keep the wiper wire safe. Srilashmi, keep it safely. They say minimum of 5 passes, but then if you look at the latest trial, the Eclipse trial, the average was around 4. 3 to 4, 3 point something. That's what they've done. So that is in heavily calcified lesions. They've done 3-4 passes. But people who routinely do, they say 6-7. You'll get much more luminal gain. But as you keep doing more and more, you tend to see slow flow. Now we'll do a shoot and see. Vishnu, shall we take a small cine and then? Back bleed and. So it's basically a compromise between slow flow and the luminal gain that you achieve. So here initially we never saw the ST depression. Now we are seeing with orbital, but we do see that, but usually it settles down. It settles down with some intercoronary necorandal things like that. But in the data, in the literature, if you look at the studies, the Eclipse trial, the Orbi2 trial, there in intractable slow flow was seen in approximately 2% of patients. Intractable slow flow, wherein the orbital study was. We leave it there. Okay, we'll take a shoot. Okay. Okay. That's all right. Okay, no much of slow flow. Now we'll go with the run through wire, take the wiper wire out. Then again regarding the slow flow, in the Orbit trial, wherein there were some 450 patients enrolled, it was actually intractable slow flow was in 2%, which means that it's much higher. The incidence is much higher, which is managed with some intracoronary spasmolytic cocktail. And in this particular trial, the latest one, the Eclipse trial, wherein 2000 patients were enrolled, there again it's around 2%. The slow flow is around little less than 2%. It's around 1.5% or so. Vishnu, Eclipse around. Come caudal. You can always go with the microcatheter and exchange it, but it's not a difficult wiring. So we'll go with the wire with the regular workhorse wire. Yeah. Then we'll take out the come cranial. Somebody can take a glove and then you can take the wiper wire. Okay. We'll take out the wiper wire. Hoop വേണ്ടേ സുമിയ? ഇങ്ങനെ അങ്ങ് എടുക്കാം. ഫ്ലൂറോ. ശ്രീലക്ഷ്മി ആര്? Angel. Okay. You can do with one device. Yeah. Same day. 12 to, they say it's around 12 to 14 hours. this doesn't get spoiled very soon unless and until you are extremely not careful with that. It wouldn't bend like rota wire. Rota, it's a small curve. Yeah, certainly. You need to have a bend. Basically, it's a coordination between you and the technician who is routinely used to the OCT device. So the pressures are okay. We are reasonably in. You guys are ready? Okay, auto calibrate. Yes. Okay, enable pullback. Activate. Okay. Always wait till the OCT catheter, the lens, it moves back to the resting position and then only take it out. That's what is recommended. See, once the imaging was done, I just took it out. That's not the ideal way of wait for a while till the catheter, the lens, it moves back to the resting position, then take it out. Okay, we'll see the images. Now 3 balloon, give a 3 balloon, 3. So that's the distal vessel. Then as we come more proximally, this is the area where we saw the, now we can see that at 9 o'clock position use. This is what we commonly come across. Even with a rota, you don't see anything more than this. Here you can clearly see that the polishing has been done at 9 o'clock, 10 o'clock position. You can clearly see that. This is the sort of volume reduction that you see with rota also. But not so much. This much we usually do not see with a 1.5 bar. Unless it will go with 1.75 or 2 bar, you wouldn't see these sort of sanding seen. Now here you can see that at 9 o'clock position, 8 o'clock, 7 o'clock, it's a clean removal of calcification there. Again, that is very clearly seen. Here again, you have a significant, you can see that it's smoothened out, that particular area. Here it's all smoothened out. This is what you wouldn't see a wonder happening following an orbital atherectomy or a rota, but you have a significant volume reduction. Once you're done, yeah, it's a calcium modification has been done, enough and probably more. This is what we would expect comparing with the initial images. Here, this was the area we saw some calcium protruding into the lumen. So all those things has been removed off, it's been shaved off. So you can clearly see that this area, these areas, it's a smooth lumen that has been created with orbital atherectomy. And then as we come more and more, so those areas, the initial, the second half of the vessel, that's just that just the calcium protruding. Initially also we saw that, right? Then as we come more proximally, till now we were seeing the distal half of the vessel. Now in the more proximal vessel, this is some small thrombi. We always see this sort of, as we keep doing more and more passes, these small thrombi also are seen, but then they say that this is an intimal lifting. Here it looks more of an intima is being lifted up. So rather than we do, almost always we see some thrombi following some 5 or 6 passes. We also see these sort of intima being lifted up. You can see that clear sanding has been done in this particular area, 2 o'clock position. And that is, this probably may not be totally an intima lifted up. It might be a small thrombus also over there, red thrombus. Here again, you can see some thrombus. So always it's like during the procedure, if it's a prolonged procedure, thermal injury can happen. You can have some thrombi also. So here again, you can see some thrombus. If you see more and more of this, we start tirofiban or tirofiban or cangrelor or these are the option. No, we just give her the regular dose. Vishnu, dilatation done? Yeah. We'll finish up with the dilatation and then do a repeat OCT run. So again, in the proximal half also, we have seen enough of sanding being done, because we never expected that, because the lumen was quite good. Now we can see that so much of sanding has been done in the proximal portion. And now we do the balloon dilatation, a repeat OCT run, and then we go with the stents. Be ready with the stents also. Yeah. 25, 20, 25, 20. Yeah, pass. 25, 20, 25. Because see, here we had an advantage that the imaging catheter was closer to the nodules. It was closer to the, which means that the orbital device or even a rota would go do something, do some good for that calcium modification, for modifying that eccentric calcium or the nodular calcium. But if the imaging catheter is away from the nodule, then probably orbital only would be the answer. Rota may not really help in that situation.
Okay.
You can always, again, depends on the cost involved. Patient is quite affordable, you can go, because orbital itself is expensive, and beyond that, going with a IVL would be much more difficult. No? Yes. ഇയാൾ ആദ്യമേ പറയാത്തത് ഞാൻ മറ്റേ കൈ ഇതിലിട്ടോണ്ടിരിക്കും. Most of the time it just opens up, unless and see the trial, the major criticism regarding the orbital trial, the eclipse trial, they've taken one group severe calcification, just balloon dilatation, the other group orbital and balloon dilatation, non-compliant balloon dilatation. The outcomes were almost similar. So retrospectively looking at this particular case, if we hadn't taken orbital, we would have dilated with some sort of balloon, an OPN or something like that. So I probably felt that is not the way how the study should be done. It should be done in extreme calcification. It's not severe calcifications. Also, majority of them you can get away with a balloon-based strategy. So they
mean luminescence of 67%.
It's all the US studies are all the sort of cases Dr. Siad Ali shows us. You tend to think that there is some calcium. He'll show all orbital and okay, we'll do an OCT pullback. We'll give some nitro, Vishnu. We'll give some nitro and do an OCT. And stent a 3.5 into, what is the length based on this? Okay, from there till the ostium. Okay, from there, okay, come till the ostium, back, come backwards. Okay, now hold on at ostial LAD, it's around 28 millimeter. So we'll take a 23 distally. Now come further more proximally till the guide catheter, into the guide catheter, into the guide catheter, into the guide catheter, into furthermore, come more further. Okay, so probably we might come somewhere till here. This is around 40 millimeters. So we'll take 23 and then probably a second 23. A 323 signs and then a 3.5. Ali Vishnu, we come till the ostium, right? We'll come till the ostium. Ostium left main. Okay. There is, ultimately it's the common sense. Many times you tend to feel that it doesn't get occluded. The ostium looks quite good, no? Even in OCT. Here you could look at the angle. Yeah, please tell. Routinely. Here again, if you look at the OCT image, we can once again discuss that. The angle is looking good. There is no lesion opposite to the. Yes, no, routinely we never do that. We try to avoid rather than. We always see that at the end of the procedure. You can see the, but again, it's a million. The trade-off between a distal dissection at the ostium versus a neoatherogenesis, a novel atherogenesis, perforated atherogenesis, will go. Okay. Okay.
Enable pullback. Activate.
The primary operator always tells them activate, but they also keep looking at the image clearance. So before we tell activate, they might activate it. So it's basically the synchrony between. Image looks quite good. So now once again I go there. Now Vishnu, we go ahead with stent implantation. Now looking at the the image over here. This is the circumflex artery. The ostium looks quite wide. You can see that it's not a very narrow angle over here. So it's a wide angle. So the chance of having a carinal shift will be less likely. And also you can look at the BPCT length also. That is the branching point. This is the branching point till the carina tip. It's almost 3 millimeters. Less than 1.7 millimeters, chance of side branch compromise is more likely. So here it's almost 3 millimeters. So chance of side branch compromise is less likely. No significant plaque opposite to the circumflex ostium, and the angle also looks wide. So the chance of closing down that particular after a crossover stenting would be very, very less likely. Now we'll go into the LAD and see. Okay, these are areas where you see the fractures. At 2 o'clock position, you see the fracture. Here there are multiple areas of fractures. Here again you can see at 9 o'clock position, that's a fracture there. So these sort of fractures, you see only when you do some plaque modification, when you do a plaque volume reduction with an OCT or with an IVUS or an orbital. I'm sorry, rota or an orbital. Otherwise, you don't see, because what happens is many times if you just put in a balloon and it just tends to move away. You do some volume reduction and then you use a balloon-based strategy, you tend to have some cracks over there. So that is the distal area of the lesion. So there again, even the eccentric lesion, we are seeing some fractures over there, which probably would have been related to both the ablation strategy as well as balloon-based strategy. So we have a reasonable amount of dissection over there. Some cracks are seen. So now we'll go with the stent. 323 alle Vishnu, adelle reasonable. Here we are seeing that eccentric calcification where you are seeing significant cracks over here at 9 o'clock position. So reasonably it has been modified well. So now we'll go with the stent. And post dilatation with a 3, 3.5 and 4.5. 4.5 on the left main, just see the size, whether it's 4.5 or 5. Initial deployment at lower pressures.
Okay.
Left main is around 4.5 size. That should we come back couple of millimeter so that the next stent also can be taken 23, otherwise we might stop short. Okay. Just two because LM is a big vessel and you cannot extrapolate this 3, maybe 2 millimeters distally. This 3 millimeter, you can always stretch it to 5 millimeters, but then it's safer to stretch a 3.5 to 5 millimeter rather than stretching a 3 to 5. He's Dr. Pradeep, our senior anesthetist. They are from North India, South India, all Pradeep. When Pradeep is around, we are happy. They never come to the cath lab unless they are invited. They never come in unless they are invited. We'll pull out the balloon and see the length. Okay, so the second one also we'll go with a 23. Okay, 23 would be 3.5, 23. We always post dilate. We always post it. So the deployment is usually done at 12, 14. We pull it back 1 or 2 millimeters, then go up to 16, 18. It's like we are mostly worried about the distal dissection. That is what we are worried about. So always deploy 12 atmospheres, just pull it back a little bit 2 millimeters, then go up to higher pressures. So the distal dissection is what you want to always avoid. Shall we come out little more? Guide Vishnu. We'll take yeah, we'll always look in the cranial views, left as well as LAO as well as RAO. We'll do imaging in both the views. We'll pull it back little more. Yeah, we'll do that also, because that fluoroscopically also you'll be Vishnu, that seems reasonable. Okay, we'll do a cine. Now the overlap is quite good. We are reasonably into the aorta. Come to elevocranial. I think this would be a reasonable area for deploying. The stent is also overlapping a millimeter. Cine. Vishnu, that seems reasonable. That seems reasonable. Again, come back to epicranial. Okay, epicranial. What is the creatinine value today? 0.9. Okay, thank you. Okay, okay. I think we'll go up. 12, 14, 6. Yeah, please. People have done that. It's all very, very cumbersome. There's no point in checking with the OCT catheter. People have done. When you do pseudocontrast, IVUS it's much more easy, but with OCT it's not always easy. 14, 16, 18. Okay, negative. Now we'll come caudal. We'll be careful while taking out this balloon. Okay, okay. Okay. So we are taking a small puff to see the circumflex ostium. That looks okay. Okay, now the post dilatation balloon 4.5, 3.5 and 3. Pardon me? No, the luminal area is around 5. It's around 5. The vessel size is around 4.5 based on OCT. Yes.
Okay, right.
Yeah, everyone says so about the. Yeah, they are all. Perfect. Especially with imaging and all. Cranial, yes. Okay. Now come caudal. Come caudal. We'll go till the bifurcation. Little bit RAO, little bit okay, little bit LAO. LAO. Okay, that's good. That's okay. We'll go up. 12, 14. 12, 14. Negative. .5. Another 12, 14 and 16. 16. Okay. We'll pull it back little more and try once again. Okay, okay. Once again 12, 14. Okay, wait a second. Negative. Vishnu, wait a second. Now what we do is, as the balloon is getting deflated, over the balloon we try to get the guide in, so that you don't damage the stent strut. Okay. Now 3.5 and 3. Come cranial. 3 point, shall we try with 3.5 itself at lower pressures? This 3.5. Distally we'll go at very low pressures. We'll pull back a millimeter and small pressures. Okay. We'll go 10, 12. That's enough. Negative. We'll take a small puff, make sure that there is no perforations distally. Yeah. Now we'll come back. 12, 14. Negative. Again 14. 16. Come caudal. Sixteen. Negative. Left main into L. Into left main, little more, 2 mil. Okay, 18, 20, 18, 20. Okay, final OCT run. Pressures are okay. Okay. Distal wire is in a small branch. Come cranial. Pradeep, we are done with that. Noradrenaline stopped. Proglide. Once the hemodynamics are not good, we don't remove the sheath so that you can monitor the arterial BP. If hemodynamics are reasonably stable, you can always remove the sheath on the table. No, we use Proglide and then remove. It's an Oxford wire, that's the reason. Sri Lakshmi, next patient ആരാണെന്ന് നോക്കൂ. Aditya, ready with the OCT imaging? Come caudal. The guide is actually not inside the coronary. Okay, now come cranial. Okay, we are ready. Ready? Yeah. Now the guide is right at the ostium. We are not into the coronary. So we get an idea regarding the ostial stent also. Okay. Yes. Yes. Activate. നേരത്തെ activate ചെയ്തു. I'll tell activate and then only you should activate. That's okay. We'll do it once again. Aditya, we'll repeat it once again because we are not able to see the distal stent edge. Last run. Okay, we have the lens has gone back to the original position. Now again, auto calibrate. Okay, enable pullback. Activate. Perfect. Okay. We'll wait. Ideally, one should probably wait till the catheter, the imaging catheter, the lens, it goes back to the resting position and then pull it out. It's a little bit of nitro and couple of injections, caudal cranial. Meanwhile, we look at the so coming to the longitudinal view, we are seeing the circumflex. We are seeing the circumflex over here. Then I think you are able to see that image also. The circumflex is over here. The left main is over here. We are seeing some red dots over there. We'll come and evaluate those things later on. Here in the proximal LAD, it looks as if there is some tissue prolapse into the proximal portion of LAD. Now we'll go distal and evaluate from the most distal portion. The landing zone seems good. There is no distal dissection. So that is very clearly seen. The landing zone is good. There is absolutely no dissection. As we come proximally into the vessel, as we come more and more proximally into the vessel, we just would want to see the ostial LAD, whether there is significant plaque prolapse. Okay, there is no significant plaque prolapse. You're seeing these sort of small things at 6 o'clock position. That is what you see on the longitudinal image also. So there is no significant plaque prolapse over here. Then we are coming back into the left main. The circumflex ostium is seen. Now we are in the left main. The luminal areas are 11, nearly 12. It's nearly 12. Now we need to properly evaluate the ostium, whether the stent is... Vishnu, we need further post-dilatation. Vishnu, I'll remove the rendered stent. No, we just see that it is well opposed. It is well opposed. We are in fact almost till the ostium only. There is absolutely no floating strut over there. It's all well opposed. So this is one area where we saw some calcium. Here you could see that it's almost 13 millimeters square. The luminal area is 13 millimeters square. The stent is very well opposed. Because of this particular blood artifact, we were seeing some reddish dots, red dots over here, making us feel that it's it's malopposed. But then there is no malopposture. Last two images enganundu Vishnu? Caudal cranial. This looks good. It is well opposed in the left main. The left main lumen is almost 12, 13. Then we'll come to 3D bifurcation and see the circumflex ostium. That's the circumflex ostium. You can see clearly that there is some amount of, these are the crowns that you see. There is no significant link over there. This is what you call as the link. This is what you call as the link. There is no significant link in the ostium of the circumflex. You can see that. But you could call this a link, but then there is no link. It's more of crowns over there. So you really do not, you have such a good lumen over there. You really do not have to go in and do a kissing balloon dilatation. Vishnu, here it looks good. The expansion luminal areas are good. Proximal LAD is 7, 8 or so. Mid LAD is 6 and 5.7. That also is good. No distal dissection. Expansion is good. No major maloppositions. Circumflex ostium also looks good. Images. Okay. That looks, caudal looks okay. We'll do a last cranial also. Cranial. I think we'll stop. Show us the bladder. Every time we go femoral, always check the bladder for bladder indentation also. There is no bladder indentation. That's good. There always, just to make sure that, because as you do more and more of radial procedures, you tend to see more and more of femoral complications. That's why we are extremely careful. We always puncture with the ultrasound guidance. We'll show the bladder once again. See, no, it's not catheterized. See, you can fluoro. Yeah. See, what we usually see is here you're able to see the bladder clearly, no? When you have a hematoma, the bladder will be pushed towards this side, like what you see over here. This is probably the colonic loops, but then this area, if you can push to, yeah.
ഇതിന് പ്രയാസം ഉണ്ടോ? കഴിഞ്ഞു കേട്ടോ.
വിഷ്ണു എടുത്തേക്കാം വിഷ്ണു, ഇത് പ്രോഗ്ലൈഡ് ആ. ഓക്കെ, ഒരു പ്രോഗ്ലൈഡ്. ഇത് can you enlarge the camera images? Pradeep, yeah, please concentrate on the groin. Okay. Either and
mosquito.
There is no much of data, but then people say if you see a link over there, you can put in a balloon and dilate. But then there is a small Japanese data which says that even if you do a kissing balloon dilatation, the stent apposition may not be good. Having a link without having a link after kissing balloon dilatation. Ultimately, you can just open it and keep it, not an issue at all.